Okay, welcome everybody to Humber Teaching NHS Foundation Trust board meeting in November, our public meeting, and welcome to anybody who might be watching our discussion today. So first of all, apologies for absence. I don't think we've got a full house, so no apologies. So well done everyone. Thanks for having you all here. Declarations of interest. If there's anything on the agenda, as usual, where there is any conflict of interest, then please raise it now or raise it on the item. Does anybody think they've got anything to raise, having gone through all the agendas and papers? No? Okay. Again, any corrections, any updates to Laura in the board support unit. We'll move on then to the minutes of the meeting held on the 24th of September. Before we go to approve those minutes, are there any corrections to those minutes, please? No. Okay. Is the board happy to approve the minutes? Brilliant. Thank you very much. We'll move on then to the annual members' minutes. Again, are there any corrections to these minutes? No. Is the board happy to approve those minutes? Thank you very much. Okay. We'll move on to the action log, matters arising, and the work plan. Is there any issues colleagues want to raise? I've just got one query on the action log. I just wanted an update on. Anybody else? Phil?
Yeah, just 9225, just to confirm that that's actually on the quality committee agenda in December, next week actually. We haven't got a meeting in November, so that'll be done next week.
Thank you. That was the question I wanted to ask. I knew that was coming up in the next week and thought it must have moved to that date. So if we can get that put on, and by the time we come back together, that would have happened then, wouldn't it? It'll have all been done and not done and dusted, but we'd have achieved that action. It probably will create more work, Sarah, anyway. There'll be something more out of it anyway, as we all know, but it will be done. Okay, thanks for that. Anybody else on the brilliant? Okay. So really pleased to have with us today our colleagues who are here. I see Angela and I see Katie to take us through the work they've been doing around specialist heart failure and cardiac rehabilitation services for our trust and for the communities we support with this is a really important part of what needs to happen when they have had a heart attack and need to rehabilitate. So unless there's a member of the executive director team who'd like to say something before we ask.
It's just under my item, Caroline.
Go on, Lynn. Yes,
you have said it. It's an important part of our specialist provision of our community services in North Yorkshire. So delighted to have the team represented here today by Katie and Angela. And I'm happy with that, Caroline. Thank you.
Thank you, Lynn. Over to you.
Thank you. I will just share the presentation if that's okay. So we're here this morning just to talk about our Heart at Home specialist heart failure and cardiac rehab service that we are empowering in North Yorkshire patients for living well. So the story really so far is about our community specialist heart failure and cardiac rehab services. We started to deliver the care with Humber Trust in 2018, and that was following the successful procurement of Scarborough and Rydale Community Services alongside the services for Whitby and also Pocklington. The service was previously provided through York and Scarborough NHS Trust, but it became a standalone community service model rather than a jointly delivered acute and community trust provision. So the enabled service and team development as part of North Yorkshire One Community Transformation was remodelled in 2021. We continued and still continue to build relationships with partners, providers to ensure safe governance and high quality collaborative care. So the geographical cover is quite a large geographical area. We cover Whitby, Scarborough, Rydale and Pocklington. We have a clinical triage service for all new referrals, and contact is within 5 working days for patients, and then they are seen within 10. Patient assessments can be in their own homes, in locality clinics. Clinically led rehabilitation programmes are also delivered via group class or individually in patients' own homes if they can't attend a class. And the follow-up and medication for initiation or titration for heart failure patients is following any endocardiography. So the service staffing structures, we have a Band 8A service manager and a matron, and a Band 7 team leader clinic with support for responsibility across not just those services, but other community services as well. Our Band 7 service clinical leads are registered nurses. We also have Band 6 clinicians who are registered nurses, and we also have a full-time physiotherapist. And we have a Band 4 associate practitioner who works across both of the services. We have collaborative working with local acute trusts for consultant and cardiologist support, and we have administrative support from our single point of contact, our community SPOC. So from a Heart at Home service waiting list, our latest position, which was taken for this presentation from the 30th of October, we had only one patient waiting above 6 weeks for an initial assessment. But often patients can choose to wait a bit longer because they may have a different date for a cardiac rehab programme that suits them better in terms of where they attend. So whether they attend in Malton, Scarborough, Whitby, etc. So sometimes the wait is more about patient own requirements or what they would prefer. So thinking about safe services, our cardiac rehabilitation service does have a national accreditation. It's also a vital part of the care pathway for patients with heart disease and cost-effective and evidence-based intervention to reduce future mortality and morbidity. The British Association for Cardiac Prevention and Rehabilitation standards state that every cardiac rehab service should submit data to what we call NACRA, which is our National Audit of Cardiac Rehabilitation, and that it has been shown to improve patient outcomes. We've achieved certification again by meeting all 7 key performance indicators, which include workforce data, patient groups, cardiac rehab offered, and wait times, duration, and completion of initial and final assessments. For a patient journey, we have an initial assessment at home. So end of April with a class attendance in Scarborough in July and then through to September. Brief patient history, the patient had had bypass surgery, referred to the cardiac rehab service following hospital admission because they had unstable angina and had a stent graft. The impact on this patient's life, I'll just let people read that for a minute because I think it takes it in better if you actually read that yourself, if that's okay. So from this patient's journey, the 6-minute walk test improved the effort, the scores compared to initial test. Initial personal goals were met, and to find out what I can do to help my heart, referral and support from social prescribing, and there's also an open door policy for self-referrals back into the service. So friends and family test feedback, we do receive some really good feedback. One patient's daughter said the staff are friendly, provided good treatment, listened, put things in place for mum to give her the best and most comfortable life. And she wouldn't change anything about the service because they're doing a fantastic job. And from a rehab potential, very professional, informative, felt safe as if someone actually cared. The visits were tailored and all questions were answered, and the delivery of the information in a friendly way also answered all the questions that felt were not explained while in hospital. So it's having that dedicated one-to-one contact with a person that actually gives them that feeling of well-being and understanding of their condition. And there's just a little friends and family test there, which shows an awful lot of smiley faces. So from a service development perspective, we maintain national accreditation and we continue to meet the 7 key standards of service delivery for the cardiac rehab programme. We understand the clinical demand across the geographical area and align equitable service delivery with available demographic data. We continue to develop digital opportunities And for example, we're looking at the Cardio Mobile at the moment and looking at a service specification for that, considering the 10-year plan opportunities for the three big shifts approach. So moving the care from hospitals to communities, from analog to digital systems, and treating patients, you know, their sickness focusing on prevention rather than actually what we do afterwards. So from a workforce development, we continue with the degree and master's level training with specifically leadership skills and heart failure specialist clinical knowledge, and apprenticeships training to grow our own physio and clinicians, 1 team member in a year of physio degree programme currently, and future workforce planning is expected clinical nurse specialist retirement in 2026. So we are already looking at future development. Thank you.
And my microphone was off, sorry about that. Thanks very much, Angela. Katie, did you want to add anything?
I think Angela's covered most of it. I'm really here just to support the service because they know their service best and they can articulate it well, but I'll support it as needed.
Okay, thank you very much. So are there any questions or comments about the service? Phil.
Angela, thanks for the presentation. Yeah, really, these are two parts to your service that are very much valued out in the community, and the cardiac rehabilitation. It was good that you showed that patient story, but often it's about the mind, isn't it? After cardiac events. So although a lot of the stuff is physical, it's getting the confidence back and the confidence that you can live a normal life. So that was really, really good to see. I was going to ask you a question about the long 6-week waits, but you answered that, so that's good. Just thinking about the future, are you doing any work around risk assessing and profiling the population? Because part of the sort of primary care ask moving forward is to understand what patients are at risk out in the community and to develop some proactive input.
I can't honestly answer that question. So what I'd need to do is take that away and discuss it with Sarah, our service manager, who isn't actually able to attend today because of leave. But we do look very closely at services that we deliver anyway on a regular basis so that we can make sure that we're effectively meeting, you know, the demands that are out there. When you look at some of those slides, I didn't cover all of the figures, but obviously the referrals you can see are fairly consistent and going up. But we've got extremely good relationships with the cardiologists at the Trust and also the nurses at the Trust. So there is good joint working across all services.
That's really good to hear, because that's really important. And at the other side, with primary care networks and GPs, what's that like?
Yeah, we're linked into the primary care networks. Katie's nodding her head. She can probably tell you more than I can here.
Yeah, so we're linked into all of those primary care networks within the localities, and I think that piece of work on prevention that aligns with the 10-year plan will be part of that with our PCN colleagues and with other providers, because I think that will sit. That's not just going to sit with us. That's going to sit as a population health sort of piece of work that we need to be engaged with. So we'll engage with that as part of the work we do with our PCNs and the local medical councils within the area, and also with those acute colleagues as well who run those more specialist services. So we'll sort of do that in partnership with others. I think it won't just sit with us, it'll sit with that as a part of that wider piece of work.
Thank you.
Thanks very much, Phil. Lynn.
Yeah, my question's not dissimilar to Phil's actually, but obviously there's a huge amount of work, and I know Katie's very much engaged directly around community services across the board, but particularly obviously in North Yorkshire. Lots of discussion about sort of core offers and sort of what these services should aspire for in that sort of integrated health model for the future, Angela. But I was just going to ask you if there was one message that you would want us to convey into that opportunity about your service in the future, what would that be?
That's a big question, Lynn. A very big
Sorry.
question. I don't know if I've got time
I
to
guess it's
answer that in 10 minutes.
what your wish would be in terms of where your service sort of, goes next in terms of development.
I think from a development perspective, it's making sure that we have those skilled clinicians to deliver those services and continue to support, with the heart failure, we have 2 new colleagues in post, Band 6s, who are registered nurses who will be joining the Glasgow University Caledonian course for health, the health and wellbeing for chronic heart failure, so that they can actually deliver that specialist services with the right skills. Because if we've got the right skilled people, then the service will naturally develop as well as new things come on board, nice guidelines change, things like that. So it's having those links and having the right skill set, and also preempting the fact that we have got people coming up to retirement age and what we do about that to ensure that we've got the workforce to deliver that in the future.
Thank you. I think that's really important, and Katie and I will convey that sort of workforce skills development element into that wider work in the ICB. Thank you.
I got a couple of questions. Michelle.
Yeah, good morning, Angela. Thank you for a great presentation and for the work that you're doing. I just want to say a couple of things really. One, thank you for that, because I've seen some of the compliments that have come in, certainly recently and over the last 6 months, about how you made a real difference to people, and that's what we're here for, and that's what it's all about. But part of it builds on a conversation that you just had with Lynn, really, because as you know, I lead a big piece of work with the ICB about long-term conditions, and the 2 things that we're leading on or concentrating on, because obviously long-term conditions is a huge agenda, is chronic obstructive airways disease and chronic heart failure. So you will start to see, because I'm bringing in your service slowly, you'll start to see some of that work going into and coming out of your service. So it might be easier to start to look at that. Well, what next for the service? How do we develop the service, and especially in line with the long-term plan? Because obviously there's a real shift from acute into community, and what we're trying to do is give the data. So we've been doing a lot of data cleansing, population health, which links into the work that we've just been chatting about, so that we can then start to say, well, how do we apportion that out? Which makes the last comment you've made about making sure we've got the right skills in the right place really important. So it was a plea to the ops team, which I know they've got absolutely all over it. It's just let's link all that work in, Angela, Kate and Lynn, into the work that Vanessa and others are doing from the ICB. That would be really great.
Thanks, Michelle, on that. I mean, in some ways that was sort of part of, I think that's something which I think you're doing the work from what you've presented today. You're absolutely in that space around, prevention in the community, sustaining people's health as well, and that community focus. So I think you're absolutely right, Michelle, about how you can put this into the language of all these other things that are going on, because I think it's a really important part of it. My couple of my questions was, do you get enough information? It's good to hear about good partnerships with our, colleagues across the system. Do you get enough information about patients from the acute side when you actually start the rehabilitation? That was one question. The other question I wanted to ask was about when people, because I had a friend not in the area that you represent, who had a heart attack and had rehabilitation. So I personally know how important this is. But do you have once the rehabilitation program is completed, is there anything around who picks up sustaining with that individual, if there's been, trying to encourage them to continue exercise or what have you? Because actually part of it is to try and help them to think about how they can help themselves going forward. So I'm just really interested in that side of it as well, sustaining better habits, I suppose, and for them to be the expert in their own health, but also that thing about you getting enough information from the acutes after obviously they've had to intervene in the first place.
Yeah, we do get very good information from the acutes, and we have had multidisciplinary team meetings and things as well, Caroline. So the cardiologists, the relationship that we have with cardiology is really, really good. It's an exceptional relationship. So, and with the heart failure specialist nurse. So if there is ever a query on a discharge letter referral, then actually we go to source rather than, leaving it open to interpretation or anything like that. It literally goes back to source, so it's very, very good from that perspective. From a sustaining perspective for patients, then actually our services are still open to patients. They can self-refer back in to SPOC if they have any issues. And it's a very careful process for discharge. So when patients are discharged, they are discharged when, you know, it is felt right for the patient, not just for our service. It's got to be right for the patient in the first instance. And then that self-referral option is open, and we will take patients back on if they require it for further support. So the service is always there for them in the future.
Thanks very much for that. That's really assuring to know actually that, you know, you do go back to source and that there is that sort of openness in terms of the individual's needs, rather than the curtain coming down and saying that's it. So I really appreciate that. Katie, did you want to add something?
I was just going to add, I think it's also about, when we're thinking about that discharge, it's about the education that's provided as they go through. So everybody's got individual needs, haven't they? And actually, if we're delivering the education well as we go through the programme, we'll have started to pick up who will need that further support on discharge, where those needs might be best met, and whether we do that signposting into social prescribing, into North Yorkshire Sport, into those different pathways that might be there to further support somebody on discharge, so that we take a stepwise approach. So it's not that they're gone, that actually they can receive support from another agency, and we can link in with our partners to be able to provide that.
Great. Okay. I can't see any other board hands up, but, you know, thanks for giving us a sort of an insight to your work this morning. I know for some of our executive directors, they'll be well on top of this in terms of what you're doing. But for myself and the other non-executive directors, thanks very much. It's really good to hear from you today, and you know, hopefully we can make sure that in whatever happens at neighbourhood or at place, that you're very much at the heart of that work. Thank you very much, both of you.
Thank you.
Thank you.
Bye.
Great. Lovely. Okay. So that was really good. Let's move on to Chair's report. Just to flag a couple of things. It's in the report, just to update since I wrote this. The Council of Governors approved the appointment of Catherine Smart as the audit chair. Her fit and proper person test checks have all been completed and have been signed off. And we're in the process of arranging a start date. And Stuart and I have had a bit of a chat about handover as well, which is all in place. That's really great. Just want to also just take the opportunity to say, you know, thank, but also our best wishes to Priyanka Pereira, who completed her Associate Non-Executive Director programme in between our meetings. I know we've been in touch with her in other ways, but I just wanted to formally put it on the meeting today for it to be minuted, to thank her for her enthusiasm, her interest, and hope we continue to work with her as a trust. I know in the Health Stars report, there is a little symbol about how much was raised by people jumping out of aeroplanes, safely, I should say, for Humber's Health Stars charity. And one of those people was Priyanka. So our very best wishes to Priyanka, and thanks for her work with us during her time with us. I'm sure we will agree with that. Any other questions or anything in the report? Hopefully I've covered all your activities, non-executive directors, and visits you've done since the last meeting. Okay, right, thank you. We'll go on to the Chief Exec's report.
Yeah, good morning, everybody. Thank you, Chair. I'll take the report as read. There's a lot in it, as usual. There's a lot happening around the system and internally. I thank my colleagues for their great work on that. There are some policies to ratify. We'll probably discuss, I think, the AI one. I think the Chair's got a couple of comments on that, so we'll come back to that at the end, if that's okay, Chair. And we've got to note and ratify the hospital manager's reappointment process. Lots of other policies there for information, and obviously I'll draw your attention as always to the visibility piece. This is just a snapshot. Obviously there's a lot more visibility ongoing from the executive team. Just gives you a bit of an overview of some of the things that we've been doing and noting around. EPR for me seems to be still going really well. There are obviously some hiccups in that, but I thank Lynn and the team for that. They're working through them. And everybody seems to be relatively happy and getting on with System 1, so that's really positive, especially given the complexities of implementing an EPR system. Few awards that we've noted in there, and it was a shame that we didn't actually win anything from the HSJ, but we were represented very, very well at the Health Service Journal Awards, which is no mean feat, especially being a judge. I will echo, I will note that. There's quite a few executive appointments around, so I'm not going to go through them. They're all in the report, but then maybe I put in there that Andrew Bennell's retiring. I'm not quite sure if he is at the moment or not. There is an issue that he may be taking over the group, keeping the group CEO, and Yvonne Elliott just being the CEO of Horse. It's all a little bit woolly at the moment. So, but Yvonne Elliott is going to be the chief exec of CHCP from April. I've mentioned the mid-year reviews. We didn't go into a mid-year review with the regional office, and that was due to our segmentation level and our other flags in the system. We didn't flag anything. They're all negative. They're all green flags. So we didn't go into that mid-year review process. The outcome of the provider capability that we submitted, and I thank the board for turning that round as quickly as we did, will be expected in the next segmentation outcome. So we are due the next segmentation, and that my understanding is that the regional office have now looked up all the provider capabilities, assessed them, and are feeding that into the segmentation process of the North in the next iteration. So we'll wait and see the outcomes of that. I'll hand over to Lynn at the end to give you a bit of an update on the industrial action and the winter plan. Both are going well, and I thank everybody for that. I'll also hand over to Karen about the flu, because obviously we are expecting a huge upturn in flu over the next week and 10 days particularly. But I'm very pleased. I will still early at Cam's Thunder that we are second in the National League table, only a couple of percentage lower than the first place one, which is excellent not for recognition from the organisation, but demonstrating staff engagement and the importance of the flu vaccination to protect ourselves, our family and our patients. So we've got work to do, so we're still pressing on with that. There's quite an important article piece in, I think it's Lynn's report about the ADHD task force. I'm not expecting to go through it a lot here today because it's a lot of detail in there. Just suffice to say that the work that Lynn and the team have been doing, we are ahead of the curve of that report, but it will go through the quality committee and back into the board in relationship to that and the recommendations. Lots happening on the professional update. I'm sure Sarah wants to mention both the national and the local. Lots happening in relationship to manager regulation, and our wellbeing work continues, especially as we get into the winter months. Dr. Fofi our medical director, has actioned the work that came through the Secretary of State and the NHS Chief Executive around the doctors, which linked into the industrial action. So those points have been actioned within the organisation. And because obviously we met the resident doctors actually at the last meeting, we're working through that 10-point plan and it's almost completed. Only a couple of other things, and I'll let Sarah just talk about the CQC, is ICB consultation. It's not in the report because it came out just after the report being done, but the ICB staffing consultation has now gone out. So they are in the process of defining their structures and sharing that with staff and putting that out to staff consultation in relationship to voluntary redundancy process. So that was signed off last week. It's a particularly difficult time for staff. We have, as an organisation, offered the ICB support from a psychological perspective, and if they need that, which they have readily and gratefully accepted. The strategic commissioning framework has come through. It's a little bit vague, lots on population health, and we are still awaiting the formal strategic commissioning we've got some pieces of information from the ICB, but we are awaiting some more. And the neighbourhood work guidance hasn't come through, so the ICB are working through their original conversations and original pieces around developing it around place. and the 6 places. So lots will continue to happen, especially over the next 3 months. It is being drip fed to us, I'm sorry, at the moment. So we will get that in between board meetings as well. Lots happening on the financial front, which I know we'll pick up later. The only other couple of things that came in just after the report had been done is Dr. Laura Voss, one of our consultants, has been offered the fellowship of the Royal College of Psychiatrists, which is a huge recognition. So I'm sure the board want to thank her. There'll be a bit more in that in the next report. It literally came out, I think, 2 days ago. That's exceptionally positive. And then finally, and I'll hand over to Sarah really, just to give you an update on the CQC. We had a formal CQC inspection to our learning disability services. Obviously that follows on from the Inspire inspection that we had, well, non-triggered, by the way. This is all part of their normal process. We are due this. And then they will do a few of our units, get an overarching view of the organisation, and then we'll go into the well-led. So it wasn't triggered, which is positive, and actually it seemed to be really positive. But this time I won't steal Sarah's thunder. It seemed to be a very positive visit. But I'll hand over to Sarah, and then if we can go to Lynn, Chair, just for a bit of an update on the industrial action. But Sarah, CQC, please, and anything else. Thank you.
Thank you, Michelle. So yeah, as Michelle's alluded to, we had CQC in at Townend Court 2 weeks ago. We were notified, and they've sort of spent a couple of days at the unit talking to patients and talking to staff, and obviously having time with our sort of senior leaders within the unit as well. The following week, they did ask for some sort of more time with the sort of ward leader and matron, and wanted to spend some more time with them, and have had sort of a subsequent follow-up meeting. They've been provided with sort of contact details of carers and family members of our inpatients, and had sort of conversations with them. Following that, we've done the usual information data report submission. So I think we've probably submitted up to about 70 sort of documents that have been submitted, sort of fairly routine things as you'd expect us to submit. They've obviously gone through our usual sign-off process and been ultimately final sign-off from myself. I would say that probably CQC are turning around the reports fairly prompt at present, so I would expect us to receive our formal report potentially within the next 3 months. They did some written feedback to myself and Michelle sort of directly, and that has been sort of fairly positive, and they gave high level feedback to the staff in the areas as well. I never really like to sort of say, oh, because I always like to wait and see what translates into a report as well. But overall, it seems positive, and they've seemed to really take an holistic approach in kind of the culture of Townend and how we provide sort of person-centered care and that. So that is really sort of the approach that they've seen. So no patient safety concerns escalated at the end of the inspection, which is always the important thing to note, because if there is anything of significant concern, they have to highlight and escalate that to us before leaving. There was no immediate concerns, and feedback has been sort of positive. So that's probably everything from a CQC perspective. As Michelle's alluded to, I do expect that we will have future visits, and you know, we are ready and sort of prepared for that. I potentially expect us to have maybe a couple more, and then we'll move into the sort of the well-led domain, as Michelle's alluded to as well. But happy to take any sort of questions on that CQC bit, Caroline, if people have any questions.
Anything from anyone? I mean, it seems to be a sort of happening now. These are not happening because there's something, this is a general thing that's happening now, isn't it? At different parts of the service. And I know that obviously when we had from Inspire, you'll be accumulating learning from this for all the others that is embedded into CQC preparation across all our divisions. I think that's part of it, isn't it, as well? The learning
we do that internally, and we do it externally as well. So we always look at any reports that are published out with the trust, and actually look at any learning and make sure that comes back through our sort of quality standards group. Obviously, Townend has the same leadership as in the general manager from that division again. So that was really good that we had that learning from Inspire and was able to translate that into the Townend inspection as well.
Great. Okay. Thanks very much, Sarah, for that update. I can't see any other hands up. So let's move to Lynn. Lynn.
Thank you, Caroline. So yes, Michelle's touched on the action by the BMA in relation to resident doctors between the 14th and the 19th of November. So we did stand up our EPRR arrangements to manage that through our tactical command. The EPRR team worked very closely with Kwame's medical workforce team as well. So it is a very well tried and tested approach to BMA action particularly. So we did see some strike action. It was in the realms of what we expected. So it was low numbers of our doctors overall. So we didn't have any disruption or very little disruption to our services. The activities were covered. Obviously, there's a very strong message from NHSE about maintaining performance and activity through that period as well. So overall, we managed it successfully, and thanks to the EPR team, the divisions and Kwame's team for supporting that as well and supporting it so well. However, obviously we are potentially going to face further potential action. So we remain ready to pick that up as and when we need to as well. And we'll repeat the arrangements again. Michelle touched on winter as well. So we are in that officially the winter period now. So following our winter plan. We got a little bit tested on that plan last week with the adverse weather, particularly in North Yorkshire, and snow in copious amounts in Whitby particularly. But again, I thank our staff in Whitby actually. There were road closures, there were school closures, so they did manage that. They prioritised their clinical activity, so thank them for that as well. But it always does test our plans a little bit and just make sure that they are robust as well. And I have put in my section of the report a brief summary of the ADHD National Task Force report. The first report was actually published in June this year, and then a couple of weeks ago NHSE followed that up in terms of sort of what of the recommendations they supported in that plan as well. So there is a summary there. We did review the original report when it was published in June, and we have been following that in our sort of service redesign and models going forward, and that's very much evident in the updated model we've put to our ICB as well for ADHD for the future. So we will bring that through the quality committee in terms of the work that we're continuing to do. So happy to pick up any questions in relation to that. Thank you.
Thank you, Lynn. Stuart?
Yeah, hi, Lynn. Thanks. Specifically on the ADHD recommendations. So I know it's going through quality committee, but I'm quite interested in whether we're seeing, is this a change in approach, or is it, and does it have resource implications in terms of shifting more resource into this area? And the reason I'm asking that is because yesterday at the audit committee, we were looking at this, the risk profile for our whole trust, that, you know, the neurodiversity waiting list continued to cause us concern, and we haven't really made any serious decisions to increase the level of resourcing into that area. And I wondered, in relation to these recommendations, what the implications for resourcing might be.
Yeah, it's interesting, Stuart, as well. If there's any resource, it's the resource that's going into schools in particular around the mental health support teams. And we've talked about that here, that the expectation is obviously money was released for those a while ago. Now we've got to ensure that that resource is in schools and is effective. Bar that, there isn't any as yet identified further funding for this, but obviously this is change in approach, particularly the expectation that it's more integrated with primary care, interestingly as well, that obviously the, and we've talked about it here at board, haven't we, that, you know, this is, you know, in terms of, you know, people and neurodiversity, that we normalise that, it's, you know, in our populations as well. And moving away from diagnoses as the main objective to early support.
Yeah.
So, but, you know, we can do that within our existing resources to a degree. But you know, I'd be interested to see won't it in future sort of planning guidance whether there is any, you know, allocated funding, but it's not expected and the reports don't indicate that.
But has as much, I wondered not about more resource coming to us, but whether we need to consider how we distribute the resources we control into different priorities or new priorities or emerging priorities or changes of practice.
Yeah, and I think that's the conversation we're having, isn't it, with the ICB at the minute, that there is an amount of funding that's in the independent, in the private sector at the moment around diagnosis. Actually, if we were to deploy that resource in a different way,
yes,
specifically in line with what the task force report suggested, then there is opportunity there. And I think that is recognised in our ICB as well. So that's where we are really sort of pushing the direction of this work into, because that's where the opportunity lies.
Thanks.
Phil?
Yeah, it's just something that I was going to raise later. I think it's in paper 14 that a different approach to ADHD and autism is very important. But it looks like we're not going to get the full rollout to schools for general mental health support till 29-30, and that seems a long time away if we want to make a difference and actually help people and change how we perceive particularly the ADHD. So it was just a point really, that because this seems to be like, if not a key risk, but the key risk that we're not getting fully to grips with in our trust. So I think this area, and I know people have been lobbying all the way up the system, but we're still left with significant waiting lists, aren't we? And it feels to do right by these children, particularly with ADHD, we need to think about it very differently.
Lynn?
I think that's very fair, Phil, as well. Obviously, we are doing what we are able to do to ensure that we are deploying that mental health team resource into schools in the way that it is intended. So we are doing, and Michelle's leading that, which I assume is why she's got her hand up as well to respond to that too. But, you know, I think the other section I put in my report today was about digital innovation in not just the ADHD, it's ADHD and ASD pathways, which is obviously sort of clinical triage in a different way, support early again. So I do think there are further opportunities to move to this model, but the piece around schools is integral to this, because that's really how you achieve that step change in terms of early support and away from, you know, diagnoses having to be happened before children can receive that support. That is the step change. But I don't disagree with you about the time frame, Phil, but I'll let Michelle comment on that.
Michelle?
I couldn't agree more, Phil, but it is a really difficult conversation, and as you rightly said, one that I've continued to have for a long time in relationship to funding. It's something the organisation cannot fund by moving money around and services around. So two issues: one with the model that's been prescripted by the centre, which I think we've managed to overcome. So we can do some work with the teams we've already got to maximise the capacity that we do, but we do need the money that's been allocated, because it was part of the manifesto commitment from the government to mental health investment in schools. So we're having to rebadge some of the money that we're getting in to support the mental health investment in schools, and the only way we can do that is to space it out over the next couple of years. But behind the scenes, Phil, I am trying to expedite that quicker. So I'm not just saying, no, it's great, we've got a plan. I am trying to expedite it a lot quicker. And then internally, we'll continue to review, as Lynn says, our service offer and our model, because I know there's ambient voice technology now that a lot of neurodiverse services are using. So there's a lot more technology that we can use. I'm not saying it's a panacea for everything, but there are some other options that we can continue to explore as that digital world gets a lot better for us. So absolutely right. We'll continue to do what we can. As Lynn said, the main thing for us at the moment is to move the money that's been spent on Right to Choose into the providers within the NHS at the moment, because that will make the most impact and the quickest impact, and the money is already being spent by the ICB, so that the ICB are already spending it on Right to Choose. If they then get, and then that causes problems because they're about medication, I won't go into all the clinical aspects, but then if they shifted that into a lead provider model, which is what we're trying to have a real detailed conversation with them, we can make a faster inroad into that waiting list and the issues that we've got. So it is a long-standing conversation, Phil, but I'm happy to take offline, but I'm hoping that's helpful.
Okay, thank you. I found this really interesting in the report, and it made me want to, actually, I'm going to go and read the report actually about it. I think, you know, this will go through your committee that you chair, obviously, Phil, Quality Committee. I suppose, you know, not underestimating at all the resource issue that we all know is a big one here, is just sort of a bit more of a sense around what aspects out of this report we are doing or we will be doing. I know there's this, the Do It profiler tool. I actually went online last night to have a look at the company that does this. What we can do within our power, and we are doing with schools, and in doing that, what's our evaluation of the impact it might have and outcomes? That's what I'm really interested in. We can't do everything for all the things that everybody said, but I suppose, Lynn, it's just getting a little bit more, particularly at the Quality Committee, about, yeah, okay, we're changing what we're doing here. Well, why? What we're trying to fix with that? What difference is it going to make, type of thing as well. And I will sort of maybe have a conversation with you offline, because at the recent NHS Providers Conference, I did meet, I think, one of the chief execs from the London Mental Health Trust based in North London, where they have every school, I think it is in the London Borough of Camden, I hope I'm correct on this from memory, and we might do it, that use this, not just use for general children and young people's mental health, the Thrive model across schools. So again, where we're working with schools, a bit of an idea about which, in terms of our capacity across the schools that we deal with, is 50% signing up for this, 100% signing up for this. It's sort of having a bit more of that, you know, in practicality, what we can do within our power to make some changes and what difference. I think that's what I would hope the Quality Committee can sort of look at a bit more for us.
Caroline, around the schools that these services are working with at the minute, and no surprise there is variability about the partnership and the quality of that partnership with particular schools as well. So we obviously do work on that as well with our local authority colleagues, obviously, because they are integral to that. But that's a very good point, because if we can't reach schools in a way that we are able to, then obviously that is going to impact outcomes, isn't it? So
and I think that's
it's a really good point. Yeah.
I think, I mean, we need to be honest, don't we? We're not honest, that's the wrong word. We need to be able to be realistic about this for obviously for the assurance committees as well, about, you know, what the aim is, but what's the practicalities that maybe affect our reach and outcomes. Yeah. Michelle.
Yeah, no, just to obviously to reiterate that as part of the national work that I'm doing on neurodiversity and particularly ADHD, we are aware of all the different organisational practices and what they do, which is, we do a lot of the work that actually the London boroughs do where we can do, but a lot of it does not work in our rurality, which is the issue, which is why we had to change the national model when it came out for mental health investments in schools, which we've done, which is great. We can move the money around and make the money go further. I mentioned, just briefly mentioned, one of the main things that's coming out of, I'm not going to say that the organisation, but I was having a conversation with their CEO yesterday, is ambient voice technology. So everything and we do with the Thrive model, as you know, we use the Thrive model in our organisation, but that seems to be one of it's not without a cost. So the issue is, it is exceptionally expensive to set up, but it does seem to be having really positive effect on outcomes, but also capacity. So I've asked for some more information. So I'm just to reassure the board that the national work that I do, I link into all the organisations to see what they're doing, because I'm pulling that back for the centre team, if that makes sense. So yeah, have a look at the report. It will go through Quality Committee, and we will, the briefs obviously in the Chief Exec's report, but we will keep up to date with that, because there are some specific recommendations for organisations as well, which we'll need to follow through, and we are following through, because as I say, Lynn was ahead of the curve on this anyway. So really difficult conversations, and no doubt we'll continue to have them.
Thanks for that. Thanks, Lynn. Was there anything else in your your huge area that you in the report. Anything else you wanted to flag? I think
there wasn't anything particularly, Caroline. Winter obviously is dependent on prevalence of winter viruses. So I'm really pleased we are in such a strong position around flu. And we know obviously the flu period has appeared a bit earlier than it usually does as well. So, but protecting the services from absence by staff and closed beds due to infection control issues was the key learning point from last winter. So I'll keep on reiterating that. That's why our focus is where it needs to be.
Thank you. Are there any other members of the EMT who'd like to flag some things? Karen?
Yes, excuse me. I'll be very, very quick. So yes, I think between Michelle and Lynn have mentioned flu. We are expecting some updated figures, hopefully today actually, in terms of the national position, but early indications are that we're continuing to perform really well. And that's in line with our really kind of intelligent model of going to the lowest performing teams each week and being really proactive in terms of understanding where there is lower engagement. But there are some final clinics remaining that are being held. We're also going to do a bit of a communication around some of the myths, because I think we're getting to that stage now where our figures will start to plateau over the next few weeks. And so actually, if we can convert some of those individuals that maybe are hesitant for whatever reason, by dispelling some of those myths, we might be able to move those people along with us. The final thing that I will mention that Michelle didn't touch upon is the staff survey, and I love to speak about it. So we're performing incredibly well with the staff survey. It does close this Friday, so we are in those last few days of the final push, as it were. But as of Monday, we were at 61.62% engagement with the survey, which is higher than the 50% closing figure last year, which is amazing. I know that does create a certain level of nervousness amongst some of us in terms of what that will say, but I am remaining optimistic as ever. And also really want to celebrate the engagement with the bank staff survey, which is at 31.6%, which seems low, but it is far surpasses the figure last year, and it's 19% nationally at the moment. So 31.6% is really good engagement from the bank staff. So like I say, few more days, but we're nearly there, and then we will expect the kind of early release of the raw data probably at some point towards the end of December. Thank you.
Thanks, Karen, very much. And just for the record, all the board have been vaccinated with the latest flu vaccine for this year, and so nobody is having this sign behind them without actually having been vaxxed. Just to put that on the record there for everyone, for anyone watching. Okay, anybody else from the EMT? No. Okay, thank you very much. Let's just go back to these. We've got associate hospital managers reappointment requirement ratification, and we've got some policies. Michelle, do you want on the policies? Steph.
That's all right, Caroline. I've just put my hand up. On the associate hospital managers, just for assurance, I did chair the reappointment panels for each of those 4 people and would support the recommendation.
Excellent.
So why don't we just deal with that straight away, just to ratify, and I'll just say the names out for the record. Anne Crick, Angela Laughlin, I think that's how you pronounce it, sorry if that's wrong, John McGorrigan and Sheila Trevor. They are the names put forward for reappointment. Is the board happy to ratify those people and thank them for all the work they do, and all the other associate hospital managers as well? We really value your contribution. Thank you very much. So the policies, Michelle.
Yeah, they're just here as always. I think obviously the chair had some comments on the AI one and the blanket restrictions, but which I'm sure you can pick up, Caroline. But they're using for ratificate. It's been through all the governance processes, being signed off by all the expert groups, etc. They come here just for the final stage. Just to reiterate to the board, we don't have blanket restrictions unless they're actually within the policy. We just don't. It's not something that we have. But we have to have a policy on it, because there are some, for example, I know that Cameron's going to pick up the smoking piece. We do have blanket restrictions on smoking for obvious reasons, because smoking in public places is no longer legal. So that's one, but it is very, 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 very rare, and there is a full policy to go through that has to be signed off by relative executives as well. So I think you had a comment on the AI
Yeah.
piece,
Yeah.
Caroline, and I think you had a comment on the blanket restrictions,
Yeah.
if you want to pick those up. I have responded to them, but I'm happy to take it further. We may need to take certainly the AI one back to the expert group. I'm hoping we can get the blanket one agreed today. So over to you.
Okay, so just on the blanket restrictions, I appreciate that we try to limit blanket restrictions as much as possible. It was really just for clarity, because obviously yesterday at the audit commission, there was audit committee, there was a discussion regarding some fire alarms going off and vaping and smoking, what have you. In the policy document, it just refers to smoking, and I'm not making a judgment either way. But I just wondered, given that, you know, smoking could be both cigarettes and or vaping, whether that needed to be made clearer in the policy guidance document. And there may be very good reason why it's just left at smoking, but I wasn't sure. And I suppose in terms of policies and guidance, I just always think for staff, it should be as clear as possible as to what we're talking about. So that was just the one on that. On the AI one, there were a number of sort of, to be honest, typos that I went through. And I can just send them in. But I suppose the biggest issue for me in question is under the equality impact table in it. My question is whether the definitions that are being used against the protected characteristics actually reflect the Equality Act as in line with the Supreme Court ruling. That's one issue. And so I've made some amendments to that, both under sex and gender reassignment. But the other issue for me is there's the fact that the final column in that talks about potential outcomes that are negative for different groups through stereotypes. And pretty much in all the areas, it suggests that when you're using AI, you should be watching out for these things. But when it comes to sex, it just doesn't, it sort of doesn't acknowledge that. And I feel that particularly in terms of AI intelligence, that there can be issues where, and I think this is as much as the case in health and science as it is in other fields, where generating data and information could actually create negative stereotypes, particularly around women in terms of sexism and misogyny. And I just don't know why that wasn't added into that group of people, because undoubtedly sexism, misogyny is a global issue. There are some countries, for example, have very different attitudes in terms of their law to women compared to others. And therefore, I think it should be acknowledged that when we're using AI, we should also be alive to the fact that you could get negative stereotypes, but also impacts that aren't taking into account the needs of women as defined under sex in the Sex Equality Act of 2010. So those were my two issues.
That's Caroline. Kwame's got his hand up, I think.
Yes, on the impact assessment, I've been having a conversation with Matt, who led on the program, and we're happy to take the comments and add it onto the quality impact assessment and to reflect the issues that you've raised in the paper. In terms of the male-females, Sarah, you are here already. I did send it this morning to you in terms of the impact assessment, in terms of the male-female. Is there something that we could do on the quality impact assessment? Because we review it based on our health inequality conversation.
Yeah,
we can. Go on, Sarah. Go on. I've got a suggestion, but go on.
We can definitely review the template in the light of changes. We did review it with input from John Duncan as our EDI lead, but we can certainly look at it again.
So we're reviewing the template now. We're reviewing the content that we've put into the template, because the template, as far as I'm aware, does cover what we need to do. The AA policy may not, but so where have we got?
I actually have a question about the template, because I don't think the template is in line with the definitions within the Act.
Okay, well, we obviously see the template every meeting, so we need to take that away. So Karen, can you take that away? And we'll do that. But going back to the AI policy, so that's something that we'll review, and we'll either feed back to the board or we'll change the template. But we do see it constantly at various committees as well. The AI policy we are ahead of the game. So you know, I think it's a really good piece of work to put my cards on the table, because we're one of the few organisations that actually has got an AI policy, because you know it's classed as a medical device, and especially given all the work that we've been doing on digital. But I'm happy if the board wants us to take that back into the group to have another look at it. It has been through all the experts within the organisation. We've got very little to compare it with, because there aren't many organisations that in fact we're sharing ours actually with other organisations. But we can either agree it today but we can look at the impact assessment template, or we can bring it back. But it's open to conversation, Caroline.
I think overall the AI policy is very, very good. I've read it word for word through. My main issues around the body of the AI policy is in terms of some duplication and some typos and grammar in it that needs to be sorted out. And I'd say that about other documents as well. I just think if we're going to have a document that's going to be used for guidance, it should be without those things there. The issue for me is, and it does apply to other templates as well, and I've raised this before, is we need to get some consistency around what we're applying in terms of the legislation to our templates on equality and definitions. But also the other bigger issue is, I think AI, you have to be alive to the fact that AI and gathering of data intelligence and what have you can have, in some cases, a negative impact on women in particular, as well as on race and on disability and on other matters under the Act as well. And I just think that's an omission that should be rectified.
Okay, well, I think you're right, because obviously we did have a conversation with Matt about actually seeing some psychosis from using AI, not within the organisation, but within his clinic. So should we take that back in, Kwame? Should we take that back into the group then? Do the board want to see the policy again?
Yeah, well, I'd like to see.
Okay, right, we won't enact the policy, we won't ratify it, and we'll take it back into the group today, and we'll bring it back to the board through EMT, if that's okay. Stuart, sorry, you've got your hand up, I didn't see it.
Thanks. It is on this policy as well. Just in terms of sign off and approval. So I think the policy says that the digital data group is where the approval gets made. Does an approval come anywhere else after that? Because the reason I'm asking is because there are certain things that we see as a board, which are often in the financial domain. Do we see these sign-offs as well for visibility and understanding?
Yeah, we've got a policy of policies, which again we've been through with before in the various groups, so we can recirculate that up to the board, so you can show the life cycle, not just this policy, but all of the policies that we agreed some time ago, and we keep reviewing, so we can send that out, Stuart.
No, my question is, if a product is approved by the digital data group for acquisition, but for procurement.
Oh, sorry.
I mean, where else is that? Do we as the board then see that decision?
I think it depends on the value, but I'll pick a Pete. Do you want to answer that? Depends on the value, doesn't it?
I think you've covered it, Michelle. I think it would depend on the value, but ordinarily, Stuart, it would be part of the big digital update that's in the chief exec update. We'd normally highlight in there any products that we're developing, as we have done this month.
Yeah, it would just because it feels such an important part of innovation that I just want to make sure that those of us who aren't involved in those groups also get a chance to understand. Okay, what are we setting up for ourselves here? Thank you. So through the B digital group, that comes up through the reporting lines. Yeah. Okay. Thank you.
Sorry, and just remember, Stuart, that we are reviewing the governance of the digital on the back of the NHSP work that we've been doing. So, we're really pertinent point there, but we are looking at that with NHP as well.
Yeah, and it's also I'm asking the question in the spirit of just keeping the organisation more generally up to speed with innovation and what we're doing with these potentially exciting and high implication tools. That was behind my question. Thank you.
Thank you, Stuart. Okay, let's just go through this. I've got no comments. You'll be pleased to say on the ventilation policy, Pete, on that one. So let's start with that. I'd be happy to ratify the ventilation policy. Yes, okay. In terms of clarifying on the blanket restrictions policy, just what we define as smoking, I think you said, Michelle, you were, have a look at that, but subject to that, do we have to ratify the blanket restrictions policy? Yeah, great. And the artificial intelligence software medical device, that's going to have a look at and then come back to us for ratification. Once that's been looked at and come back, can that be done via through just sending it to all of us, or does it have to come back to the board meeting in January?
Because it's a full policy, it's a new policy, it probably needs full ratification at a board meeting, Caroline.
Okay, all right then, thank you very much. Okay, let's move on then to the next item on the agenda, publications and highlights report.
Thank you, Chair. I'll take this as read. It's our usual publication, a highlight report on all the major pieces of work that have come in and while we're responding to them within the organisation. There is a lot happening, as you can see, and you'll hopefully see some of that all the way through the reports that are on the agenda today. But I'll leave it there, Chair, unless there's any questions.
Any questions from anybody? No, thank you very much. Let's move on then to the health inequalities update. We have Sarah with us. Thanks for your patience, Sarah. Thank you.
Thanks. So I'll be brief and I'll just pull out some of the key points from the report that we've submitted. In terms of understanding health inequality in our services and communities, we have been creating some additional data dashboards, for example, around talking therapies, which have been really useful for doing that analysis of outcomes for different groups of patients. It's not in the report, but I did just want to mention that a new NHS England statement and information on health inequality has been published in the last couple of weeks, which determines what we need to consider publishing in our annual report. The suggested content on health inequalities is much more extensive than in previous years, which I think is a really positive thing because it'll help us build up the picture of health inequalities within our services. But it's going to be a lot of additional work. So I'm reviewing that with the BI team at the moment to see how we take that forward. We've been continuing to work with our QI team to identify activity which addresses health inequalities. Lots of great projects coming through, particularly those that have been generated by the Culture of Care programme, and they're starting to make a real difference to the patients on those wards. We mentioned health inequality impact assessments. Really pleased to say that since it's been introduced a year ago, that broader health inequalities impact assessment includes the broader the categories. We've had over 149 completed, so it's starting to make a real difference to the way we think about our policies. We have done a lot of work around communications with patients. So the comms team have been leading a project on accessibility of documents. We've now got an accessibility checklist, which applies to all patient-facing documents. And comms have been reviewing those documents to make sure that they are to the standard that we'd expect. We've been working on a reasonable adjustment policy to cover all services in the trust. We've now got a draft policy which has been produced with involvement by experts by experience, which has been really great to see, and that's really influenced how we have shaped the policy and the language that we use within it. Thinking about the way we deliver care supports health equity, one of the big things that's happening is the rollout of Dialogue Plus training. So Dialogue Plus is a sort of assessment and formulation tool which does identify some of the patient's needs in relation to their wider conditions of living. So it talks about their satisfaction with their accommodation, for example, and their social relationships. So it really links into those wider causes of inequality. In terms of the wider causes of inequality, we're doing a lot of work at the moment around financial inclusion. So we've held some co-production workshops to think about how we address that issue. And some of the ideas emerging for that are how we work with some of the voluntary sector organisations such as Citizens Advice, who really specialise in providing this support and improving access that our patients have into that support through using professional referral routes, but also how we improve the information that we have for staff and patients on how they can access support, say with debt or housing, and that aligns with a project that comms are leading to produce a leaflet library of all the patient-facing information that we have, which will include those wider topics as well as clinical documentation. We've relaunched the Community Mental Health Grants Scheme and have started awarding the first grants to support mental health and wellbeing in underserved communities. One of the questions that we added to the application form this time was to ask applicants to provide us with information about the strengths and challenges facing those communities, which is great because it's bringing in some really rich data around the communities that we support and some really valuable insights into those communities. And lastly, on working with partners, we've joined the Prevention Concordat, which now brings together Hull and East Riding in a single meeting. And we've been doing a lot of thinking around neighbourhood health. I think this is going to link into the work that we're doing around planning, the work that we're doing around Foundation Trust accreditation, and possibly further conversations around IHO status due to the emphasis on population health within that. So I think that's an emerging and developing conversation.
Thanks very much, Sarah. Sarah, can I just say, I think this outline report, as you did last time, is a really excellent report tool, and really clear. And I really feel, actually, you know, this starts to paint a picture of how we're building the foundations across the organisation for much more ability to identify where those health inequalities are, but also, you know, learning for our staff and understand that. I really appreciate that. I just wanted to ask, I noticed in the first box, it says a briefing's been created for non-executive directors exploring health inequalities experienced by women and girls in our services. It might have gone to a committee. I'd love to see a copy of that. I don't know if it's been circulated amongst all of us.
It has, but we'll make sure it's recirculated.
Thank you very much indeed. Thanks for that. Any other questions? Stuart?
Thanks. Hi, Sarah. Yeah, just echo the reports about the clarity, Caroline's words about the clarity of this report. It's very good. A couple of questions. Who are the recipients of community health grants, and how are we evaluating the effectiveness of those grants?
So they're grants to small organisations who tend to be delivering things like projects which are supporting older people with social isolation, for example.
Got you.
So it's these very small community grants that are working within those communities. You know, delivering stuff like sports activity was another one, you know, involving people in social and sporting activities to improve physical and mental well-being. They are asked to submit an evaluation form, which covers, you know, how many people they've supported and what changes they've made. But we are conscious that some of these are very small voluntary-led organisations, and that we can't put an onerous requirement on them when they're accessing relatively small funding. Is in some cases it's up to 5,000, but in some cases it's just a few £100.
Thank you.
Great. Phil, and then Steph, and then Dean.
Sarah, thanks for your report. It's always great to see what we're doing as a trust. In general, the NHS have not been terribly impressed by its approach to health inequalities in recent years. It seems to come very narrow. We seem to keep a nice broad focus. But moving forward with the 10-year plan, health and wellbeing boards are going to be responsible for neighbourhood health plans, and the ICB is going to be responsible for population health data. And part of my personal development, I've got appointments coming up to talk to all the directors of public health. If there's any questions you'd like me to ask, or any access to their data that will make our job easier, so that we don't have to go looking as much, could you let me know in the next week or two? Because I'm about to start meeting. It's for to understand the area better, so that I can get a feel for whether the councils have got real priorities with mental health, learning disabilities, neurodiversity. Because I've just got a nagging sense that we all talk about it, but are we making a difference? That's my nagging passion, that I want to make a difference to. So if there's anything that you'd like to know from the Director of Public Health, could you let me know, and I'll use it as to format some questions?
I will go away and have a think about it, but we do use a lot of public health data, and they're very good at publishing all of it.
Well, that's good to hear.
Thanks, Phil. Steph?
Thanks, and thanks for the report. Oh, there we go. Thanks.
Sorry, Kwame, did you want to come back in there on something, or before I take?
Yeah, no, I'll be happy to liaise with you, Phil. They've started a lot of data on public health, but it could be improved, and I can talk you through one or two because I've been speaking to James Craig about it. So, in the right place. Thanks.
That's really helpful, Kwame. Thank you. Sorry, Steph, back to you.
Yeah, no worries. Thanks for the report. Really, there's a massive amount of work that we're doing on a lot of fronts, which is absolutely brilliant. One of the discussions we had at Audit Committee yesterday was about outcomes. And I'm sure that is a feature of the NHSE guidance. But it would be interesting to have a discussion at some point around outcomes and what impact we're having with some of these activities that we're doing. So I'm sure that we can do that at some point, because I'm sure that a lot of these activities that we're doing are having impact. So that's the first point. Second point is, it was me that requested the health inequalities experienced by women and girls report, and I've had a look at some of that work in terms of the services we specifically provide that are focused towards women and girls. And again, I think that's an area that can be developed and focused upon. And a question for you, Sarah. The IMD has been recently re-released, the latest version of IMD, which continues to have some quite shocking results for some of our areas, particularly the City of Hull and some of our more remote coastal areas in particular, not only at the levels of deprivation that we have, which has an impact in terms of health inequalities, but also the disparity within our patch of Humber and North Yorkshire in terms of the extreme affluence in some areas and the extreme poverty in others. I just wondered if you had any reflections on the latest iteration of the IMD and whether it might nudge us in some different directions.
Yeah, it's something we are looking at with BI, that we'll need to be incorporating that into our analyses going forward. So yes, I agree. It does continue to highlight some really stark inequalities, particularly around Hull, as being a particular cluster where we've got very high levels of deprivation.
I suppose it also challenges, is that everyone looking at what they're doing and whether it's actually working, and whether they need to reevaluate. Okay, thank you for that. And Steph, thanks for initiating the women and girls work as well and asking for that. Thank you. Dean.
Yeah, thank you. Just to echo everybody else's comments about the report, Sarah. So a similar point to Stephanie's really. This is in the sense it would be even better if, but the disadvantage of showing a non-executive director a sea of green, isn't it, is that we can push further. And I think that the outcomes bit, if we could get something, it's probably tied into the BI stuff that you've put in here. But I suppose if we were looking at our patch and we're looking at health inequalities, we'd have a sea of red, and here we're demonstrating lots of green. And so it would be good to see what difference. I know some of this is generational, but even if we project, you know, if this work continues, it may have this following impact on this group of people. So it's just about continuous improvements, I think, in terms of the approach. But thank you.
Yeah, thanks for that, Dean. Sarah, do you want to say anything? I'm sort of feeling like we're building foundations, so that's going to be the next stage, isn't it, to be much more outcome focused. I think that's where we're going on this. But you're right, Dean and Steph, to raise that. Sarah?
I agree that having the wider data set will certainly help with demonstrating the impact, but perhaps not on the population health metrics, but certainly on the inequalities within our own services. We do flag in the infographic about completed QI projects, and they do have impacts associated with them where they're completed projects, because there's a benefits realisation section to the report on those. So we can start to pull some more of that data into the report.
That would be really helpful. Kwame?
Yes, I agree. I was going to separate some of the areas in which we are trying to get data to be able to demonstrate outcome versus what is happening at population level. That is why some of the issues we have within Hull, within the coastal areas, are described as wicked problems, which we have to work with everybody. So part of it is also collaborating with our colleagues within the ICB, as well as in place and in councils. So that's the distinction. So that's some of the greens are the things that we have set ourselves, such as DNA from minority areas or difficult to reach areas. Thank you.
Thanks very much, Kwame. I haven't got any other hands up. Sarah, thank you. Could you also send our thanks to Tess Owen, who I know works closely with you as a co-author of this report today as well. So thanks to her as well. Thank you, Sarah.
Oh, well, thank you.
Okay, Lynn. Item
Thank
number
you.
11.
Yes, thank you, Caroline. So this is the Emergency Preparedness, Resilience and Response EPR core standards process for this year, 2025. So we've been through a rigorous process internally this year to improve our compliance with the standards. We've been through a rigorous process with the ICB in relation to assessment of those standards as well. That culminated in a meeting with us as a provider 2 or 3 weeks ago, and a check and challenge process where all providers were brought together with the Local Health Resilience Partnership. That's where our outcome was confirmed for this year. So we've achieved 86% this time around. That compares with 60% last year. We've had a real focus this year on the standards around training. All of our tactical and strategic commanders have needed to complete portfolios this year, for example, demonstrating their knowledge, experience that they've chaired commands, etc., through that portfolio work. That's been supported by training as well, and we had a real focus on our business continuity plans. We remain challenged around the standards relating to CBRN and hazmat. So that chemical, biological, radiological and nuclear response standards. Now you'll know from previous discussions that we always, as a community and mental health provider, raise concerns about the standards and proportionality given the nature of the services that we provide. The reason why we are hampered in completing these is we need access to expertise. The ICB have supported that through the Yorkshire Ambulance Service, but because of their pressures, we are delayed in receiving that. And that's been the position for the whole year as well. I have raised that issue with the ICB. We're not the only provider, although it does seem to be me that leads the charge on this, who are also challenged by these standards. The standards are actually being reviewed nationally this year as well, so we have asked both the ICB to support us regionally and nationally to raise a challenge around this, because it does feel disproportionate in terms of where we would use our resources around this agenda. However, I am pleased with the position that we've achieved this year. Our EPRR team, I thank them sincerely. I think they've been really focused, and when I say team, it's a couple of people that are supporting this agenda. It does require us as a board to approve that I sign the statement of compliance for this year as well, if you're happy for me to do that. At the time that I put the report together, we hadn't had the LHRP meeting. We've had that now last Thursday. So I do know the outcome for the other providers in our patch as well. And I will just put those in the chat if that's okay. So you can see sort of where we lie amongst our partner agencies. So I've just pressed the button on that. So hopefully that'll come through. I'm really happy to pick up any questions. I see Steph's got a hand up.
Steph.
Thanks, and thanks, Lynn. Congratulations to you and the team for a real improvement in this area from where we were a few months ago. It's brilliant work. In particular, the work around business continuity has been really good to get us to where we are. We are going to struggle to get beyond partially compliant, although we might be able to squeak
I think we'll
into
squeeze too substantial with a little bit, Steph, that we've got to achieve this year on BC. But as you say, we have actually achieved significant progress with the business continuity core standards that might just tip us over the line. However, we'll wait and see.
I think that would be, that we
would
were
be just, wouldn't it?
Yeah, that would be great. And without that position with YAS being improved or some alternative being put in place, we're going to struggle to get much further. But a really good achievement, and I think we can take real assurance from this. The important thing is, of course, that we are satisfied as an organisation that these plans are in place and they are robust. This is a checking process to give us some assurance around that. Really good piece of work, and thanks for that, and keep it up. It's excellent.
Thank you.
Thanks
Pass that back to the team.
Thanks very much, Steph. Yeah, it's really annoying around the Yorkshire Ambulance Service not being able to provide us with that resource. It's just 6 points it's really annoying, but you can see how much work's been done since last year. And just to echo Steph's points, I mean, goodness knows they need to sort that out, don't they? Because there must be others in other parts of the country similar to us who are affected by this in terms of the delivery mechanism for this.
And you can see that actually in the compliance in our ICB. Look at Navigo's, Tees Essex, Weir Valley's position as well, Care Group Plus. They're all challenged by the same issue.
Well, maybe the conversation needs to be had at a national level with, you know, if it is the ambulance services around the country that are responsible for this, how that can be improved, because we can't really do that for them, can we? Brilliant. Okay, thank you. And obviously, Lynn said she put some information around partners, obviously comments as well on this too. Is the board happy to approve this report? Thank you very much, everybody. Right, okay, we have the Guardian Safe Working Annual Report, and we have Mo with us today. Good to see you. Thanks for your patience and holding on for us. Kwame, did you want to say anything, or should we go straight to Mo?
Yeah, just to welcome Mo to the board. Dr. Quadro does a good job in giving us assurance, as well as almost working as independent in reviewing, almost a straddle between those of us in clinical management and the resident doctor, to make sure that the resident doctor's well-being is well done. So Mo, do you want to go through your report? We've read the report. Thank you.
Thank you, Kwame and Caroline. So this data will be looking at the period from August last year to the end of July this year. And the headlines are that we've not received any exceptions in relation to any immediate patient safety concerns, nor have we received any exceptions in relation to trainees or residents being able to access training opportunities and activities. The exceptions are being raised in relation to on-call work intensity. And to help remedy that, medical staffing have worked closely with relevant stakeholders to introduce, in agreement, continuous monitoring, and that started in September of this year. The take-up has been slow, but we're working with the chairs of the resident doctors to encourage the other doctors to get involved in that data collection. So what we will hopefully have as the year progresses is more data to identify where those work intensities are. So when you look at the exception data, what you identify is usually busy on calls with emergency admissions and unwell patients. So that work is ongoing. In relation to work schedules, there's not been any delays throughout the year in resident doctors receiving those. The only other big change has been that it's not an issue related to this specific trust, it's an issue across England, is the software that we use doesn't communicate with the finance department. So how it works currently is the exceptions report get reviewed by the clinical supervisor, and then it gets sent to medical staffing at the end of the month, who then sign them off and manually send them to finance, and that appears to be working. So we've now been meeting with the resident doctors on a quarterly basis at the Resident Doctor Forum. We've been monitoring that, and there've not been any issues systemically in relation to that. So that's been an improvement from previous periods. So that will hopefully encourage residents to raise exceptions. I know Kwame will be talking about the 10-point plan, and a part of that is to encourage residents to raise exceptions. The other big news is there is an exception reform update, which was scheduled to be rolled out in September of this year, but there's been delays. So it's now being launched on the 4th of February next year. And the major take-home message there is that the exceptions will go directly to either the Director of Medical Education, if there are any exceptions raised regarding educational activities. And if there are exceptions raised, they will go then straight to medical staffing, bypassing the clinical supervisor. So that will hopefully streamline the process from residents raising exceptions to then processing of those exceptions and payments being made. There's also changes in relation to fines being levied if residents are not given they're onboarded to the Allocate software or the appropriate software. And other changes include geo-tracking and how the encouraging of toil and such. But hopefully that reform comes into effect on the 4th of February. We was discussing the resident doctor forum that even though clinical supervisors are no longer going to be part of the sign-off process, that clinical dilemmas on call should be still encouraged to be discussed in clinical supervision to provide that training opportunity. We continue to work with the resident doctors. We meet quarterly as per the terms of reference. We get good conversations. It's attended well by the Director of Medical Education as well as the resident doctors. We have good open discussions, and we work very closely with medical staffing and very well supported by Kwame as well. So it's a really good, healthy, I suppose, way of working where issues get raised and we can have conversations, and that transparency is there as well. So we're building on what we've done last year, and it continues to improve. Like I said, I'm hoping that the continuous monitoring provides us with data so we can look at the work schedules to try and improve the system better so we can provide safer working and supporting for our residents and improving patient care. So it's moving in the right direction. But I'm really encouraged by the conversations that I've been having. And I also meet with the Freedom of Speaking Up Guardian. So if there are any issues, we can hopefully tie that in and kind of explore these issues before they become significant. So that is another good way of sharing information and exchanging good ideas and identifying any concerns early on. So as Kwame said, independent of the management process, I've been looking at the data. I get all the exceptions raised and I do go through them. And we've got a good relationship with the DME and, like I said, with medical staffing, and I'm encouraged by the responses I get back from them. So yes, I've got nothing further to add, but I'm happy to take questions.
Thanks very much, Mo, and thank you for another clear report. I mean, just to say, we did meet with some resident doctors at our strategic board. I think we're about 10 of them there. And whilst there were so few things they raised, nothing to do with you, Mo, you'll be pretty pleased to know. Actually, overall, what really came across was actually that there were different ways in which they could express concerns individually and collectively, and were listened to and felt looked after, I would think is a good, maybe a phrase to use by the trust. So and again, your real interest in this area and approach, which you've just demonstrated, is obviously part of that. Thanks very much, Dean.
Yeah, thanks, Mo. And just confirm, we also discussed this at the people committees we do before it comes to the board meeting, and also thank Mo for his commitment in this area, and in particular, Mo, the relationship of trust I think that you built up over time. That means we can navigate this sometimes contentious territory sort of very, very well. And I think that bodes well as we get into that 10-point plan as well for resident doctors into the future about sort of taking that seriously and doing it diligently. So thank you for that.
Thanks, Dean. Anybody else? Okay, thanks very much. You're welcome to stay for the next item, Mo, on the resident doctors 10-point plan if you'd like to. Because it's a nice little segue into that, but if you need to go, completely understand. Thanks very much. So let's move on to the next item, Kwame.
Thank you very much. So the 10-point plan was released by the NHS England in August, end of August, and within 12 weeks, organizations are supposed to show very clear action plan on the 10 points. So we started from an area of strength, and as you can see from what we've just heard from Dr. Kwadwo, we have always had a good engagement with our resident doctors. We do get good feedback from a national survey of the GMC, and in fact, we always benchmark higher than most organizations. So we started from good areas. So there are 5 areas where immediately when the whole thing was released, we were already met the requirements. There are 4 areas where we want to improve. This is because we are setting the bar higher. So there are areas such as the rota. So although we do get the rota and we send them in time, NHS England is supposed to release it 12 weeks, so we can send it in within 8 weeks. And we haven't got a lot of complaint from them, but we want to make sure the process is right. We're changing the rota software, which we're going to use, so that it gives the doctors flexibility to be able to change, which is something that they sometimes complain about. There are some areas such as induction, which we want to improve. Again, is setting the bar higher. we're doing some audit on our rest accommodation with Pete's team. We did actually improve the resident doctors rest accommodation, but we want to look at whether we can even go further beyond that. In terms of payroll, which is one of the areas to improve, we don't have errors. In fact, there was only one resident doctor who said, I had an error, but it was because my previous organization didn't send the correct data to you. However, the system expects us to be able to make sure that whatever processes we have, we can articulate it very clearly. So those are the areas. The only one area which is red is NHS England action, which would also impact on some of our areas. So in terms of action plan, which is attached, we have very clear action plans, and we would be monitoring that through the People and OD committee, as well as working with the resident doctors representative on a regular meeting to make sure that we achieve all our action plans and improve upon that. Thank you very much. And if there's any questions from members of the board or those who've heard of it, if you want to contribute. Sorry.
Thanks very much. And again, another clear report. It does what it says on the tin, and good work that's been done. Stuart.
Yeah, thanks, Corey. Yeah, good work. I didn't pick up, what was the red area? Didn't quite understand the red area.
So NHS England is, in order to avoid the difficulty of rotation, one of the target they've set themselves is to bring the resident doctor into one employer, one bigger employer, so that they're employed by one employer and then handed over to all the others. We've done that before. So that is one of the things they want to do to avoid changes in rota or changes in induction. One employer will do it.
Yeah.
So that's the red area for them, which they are looking at. With all the things that is going on in NHS England, I can see why there is a bit of a delay in that action.
Yeah, yeah. And presumably that's to speed up the bureaucracy and everything and make sure they're covered as they go through their different rotations. Yeah, okay. Is that all right, Stuart? Is that clear then? Okay, great. Phil?
Yeah, this was well triangulated when we spoke to resident doctors, wasn't it? They felt that they'd been listened to, and any issues that were outstanding were mainly outside the control of the trust, but that we still need to get those sorted. There's just a repeat way, it's probably the same paper, we've seen it several times, mentioned about investment in the capacity of medical staffing team. I don't quite understand what we need. I'm not sure I need to understand, other than it may be a bit of a drag.
I mean, as I said, one of the things which they were struggling with was the fact that we were having more and more resident doctors, and there was some concerns about if the resident doctors want to change their rota. As an example, medical staffing would have to do it manually. That was one of the reasons why we decided to use the Lantern, which is an AI system, to allow the flexibility of the resident doctors to do it. So what I've said to them, I'm hoping that once we are able to move to a better system that supports us, because we were asking for manpower to manage data. However, if we move into an AI-generated rota, hopefully that means that the capacity issue would be addressed as well.
Yeah, thanks, Claire. I mean, just only other bit was about mandatory training. Now, obviously, in the trust, that's incredibly high, but you can see that in September it dips a little bit each year. It's like triangulating the performance data later on in the meeting. Is that not fully sorted yet?
So one of the things that happens is that when we get a new batch of resident doctors, our data dips because we're doing something called passporting to make sure we get all of them to transport whatever they've done. And then we do a lot of the training, such as IG training, as a group. So we do it in September, August, September, to meet with a new batch of doctors. So usually we have that dip, and as soon as we do the IG training for 100, all of us as 100 doctors, then it goes up. So we have that kind of natural dip, but it's because of the changes in rotation.
Okay. That provides assurance to you there, Phil? There's not something weird going on. It's just a bit of a fluke of the way the rotations work, it sounds like. Karen. Oh, sorry, Dean, and then Karen.
It may be Karen wanted to come in on that point.
Oh,
It was on that point, if
okay.
that's okay. So I just wanted to add to that obviously we're active participants in the national programme of work around the statutory mandatory training review that has ambitions for portability of training across all professional roles, and that includes absolute focus on resident doctors as well, particularly because of this plan and the work surrounding it. So I just wanted to add that because we're very involved with that, and that will happen at this trust. And it does in many forms already now.
Great. Dean?
Thanks, Karen. I was just going to say that this is one of those initiatives, isn't it, that I think is viewed very seriously nationally and seen as a key component, I think, in eventually resolving the resident doctor sort of industrial action and dispute that's going on. And I think there's likely to be a lot of sort of board level scrutiny about our ability to do this well. And we've agreed with Kwame that it'll come back regularly to the people committee. So we've got that sort of updated monitoring progress, and where we can, you know, sort of close down actions that we've completed them. Many of these are enduring, you know, they don't necessarily have an end date as such, but we continue to work and focus on that, and it's great to see Kwame's got that focus on it as well. Thank you.
Thanks, Dean, for that. Thank you. Okay, that's great. So that was for assurance. I think you provided that today, and thanks again to Mo. And we'll move on to the next item, and then we'll have a break. Item number 14 then, Michelle.
Yeah, thank you. This is the usual update from the collaborative. The work with the collaborative still continues. So we do provide a report to the board, giving a bit of an update about where we're up to and the work that we've been doing since we last met. Obviously, I mentioned earlier on lots of changes at the Integrated Care Board, but we are going to continue with the work of the partnership. We're just working out what that looks like going forward. So this is just a moment in time. We'll still continue to develop those priorities. But over to you, Alison.
Thank you. Thanks, Michelle. Morning, everybody. Just hopefully everyone's had a chance to have a look at the report, so I'll just pick out some of the key things. As a collaborative, we're still continuing to work on the priorities that have been outlined for us, and just really the key summary. We're working with our ICB colleagues and providers as we're developing the plans for next year and beyond, and now we've got developed a sort of a draft set of commissioning intentions and priorities, so we'll be continuing to discuss those with providers and the ICB. I just wanted to bring to the board's attention the work that's happening around the proposed Limbic digital AI proposal for talking therapies, which has been supported by the providers, which will provide a digital front door access point, which will help with people wanting to access support for talking therapies. Still quite in the early stages, and we are working with Humber's digital team on this, but it is an exciting development. Since we've took over in the collaborative the case management function for those patients that are currently out of area, we've seen already 14 discharges. These are some people who have been in out of area places for quite a long time, and have been able to be either discharged or moved to more suitable alternative places, which is good, really good for those patients, but has also had a significant impact on the cost savings, as you can imagine. So we've currently got 106 patients out of area, either for rehab or sort of older adult placements or adult placements, and we're continuing to scrutinise that. And all of those people now have had a face-to-face review and are getting regular face-to-face reviews, and this was something that hadn't particularly been happening before. So some really good work happening within that case management function within the collaborative. There are a number of new proposals that have been developed that you'll see in the paper. So individual placement support, mental health support teams, the crisis tech services, and we are still awaiting approval for those from an expenditure perspective from the ICB. So that is having a slight impact on some of the performance metrics, as you'll see. So we're still sort of pushing pushing to get that funding approved. These are some of the national priorities that we are working to, but there has been some delay. That's probably the things that I wanted to pick up. There's a lot of work happening on autism and ADHD around the model, but making sure that we've got all of our providers together, and that's a huge transformation programme of work, looking at the funding that's being spent on the right to choose and how we can develop a model that's then developed, that's being delivered by our local providers. So I can see Stuart, you've got your hand up, so hi Stuart.
Stuart.
Hi, and I didn't mean to interrupt your flow there, Alison.
That's okay.
I was just interested in what you talk about, the case management function. So you get an active case management function, you're moving people into the right settings. So I'm seeing something exactly the same in the specialised collaborative provision. So it seems to me one of the secrets of success in these collaboratives is this active case management. So people rattling cages, moving people on. So interesting learning from both those environments. Thank you.
Yeah, and there has been a significant impact on the number. What we're focusing on now, though, is those people that are clinically ready for discharge but have been delayed. So big push on that, and looking at sort of the highest sort of people who've been there the longest and what alternative provision. But yeah, with the case managers are able to much more robustly manage. They're seeing these people on a regular basis, on a face-to-face. So there's that quality and safety impact, which is really good as well.
Yeah, thank you.
Thank you, Stuart. Can I just in the at-risk box, literally everything requires funding. So what's the sense in each of those headings in terms of whether we've got a 50% chance of getting funding or an 80% chance of getting funding or 20% chance of getting funding?
This is one of the reasons I flagged that we've got a number of initiatives that are awaiting funding that have been approved by the Collaborative Exec Steering Group. Pete might want to come in on this, but there is a protracted process now that we need to go through to seek approval through ICB expenditure panel. This is against the backdrop of the sort of significant financial challenges that the system is facing as a whole, but it has slowed down. And we've got various pots of money. So some may be particularly ring fenced to mental health. So talking therapies is a good example of that, and how we might, and mental health support teams as well. But that's what's caused the delay. So I wouldn't be able to put a percentage on that, Caroline. We are seeing the approvals trickling slowly. We've had one recently for IPS, but that has only been for this year. So clearly where there's posts involved, providers would need to look at that to see if they're able to sustain that for next year. But that's why there's been the delay. Pete, I don't know if you want to add anything at that point.
I think you've covered it really well, Alison. I think we've got our application into the expenditure panel at the ICB. There is ring-fenced mental health funding, but that funding is sat in the ICB and we have to go through a process for it to be released, which is quite time-consuming at the moment, given we're all aware of what's happening with ICBs and the wider financial context.
Okay. And I just wondered, Alison, if you could just, not maybe for now, but if you could just email me just so I can better understand the mental health support teams in schools, whether that is one in each school or whether there's a team that will cover a group of schools, like a secondary school, primary school in an area, and what is the composition of those teams? Because I'm trying to visualize what this might mean, you know, what full coverage actually means. And I might have a perception that is very different to the reality, if you know what I mean.
Yeah, but I'm happy to share, because it has been a very fixed model, a very fixed workforce model, and clearly where we've got significant amount of schools and rural areas, so North Yorkshire, where we're expected to have a team in each school, that's been a real challenge and will be financially significantly more expensive. So I know Michelle and colleagues have been having discussions with the national team about how we might have more flexibility and fidelity on that model, and that's what we're working through at the moment. But happy to send you more detail through on it, Caroline.
Thank you. Thanks very much. It just helps me visualize what we're going to be actually provided with, I suppose, and what the managing expectations, I think, in this space is with parents and families and schools as well. Brilliant. Any other questions to Alison? I Can't see anyone hands up. Thanks very much, Alison. Indeed.
Thank you. Thanks everyone.
It is,
Bye-bye.
it is 11:19. I suggest we take let's take a 10-minute break to 11:30 and we'll come back. Thanks very much. Okay, we're back on to complete our public board agenda, and we are on item number 15, finance report, Pete.
Thanks, Caroline. So this is a report as at the end of October, month 7. We've included in the report system context, if I can even say it, and folk on the call will remember that as a system, we have a break-even plan for the year, and that break-even plan is dependent on just short of 80 million deficit support funding. As a system, we've only got the data in the report up to month 6 because that's the publicly available data, but we can see the system recorded a 24 million deficit at the end of month 6, which was a 4 million adverse variance to plan. So I think it's fair to say there's a lot of focus on finance across the system at the moment, and Michelle referred to the deep dives that were undertook earlier this month, which we're still waiting formal feedback on. For the trust at month 7, I guess we're the outlier in all of this because we continue to be 3 million ahead of plan at the moment, which is a favourable position for us. And that favourable position is due to the timing of non-recurrent income. We still remain confident that we will deliver our break-even position by the end of the year. We have some risks that we have to manage, and they're detailed in the report, but our confidence is high, and I think that gives us really strong foundations for the planning round we're just embarking on. So I'll take the rest of the report as read. Caroline, happy to take any questions.
Thanks very much, Pete. Keith, did you want to add anything at all? I'm not putting you on the spot, just in case.
Nothing probably that I won't cover off in my assurance report.
Okay.
And one element in the private board, Caroline. But other than that, we're in a very unenviable position. I think my concern still falls outside of the trust rather than inside the trust, if that makes sense, and the pressure in the system and the likely pressure that will place upon us and others to rectify that position.
Yeah. Okay. Thanks very much. Okay. I cannot see anybody hands up. I mean, in some ways, Pete, by the time we get to the finance report, we've picked up a lot of these issues about the pressures on other items on the agenda. So it's not about lack of interest. It's because actually it's at the pretty much at the core of a lot of other items that we discuss as well. So yeah. Okay. Let's move on then to the performance report, Pete.
Thanks, Caroline. So again, this is performance as at the end of October. Broadly a similar picture to what we've seen in previous performance reports to the board, but if I pick out a couple of areas and then we can move to questions, or my exec colleagues may want to jump in. So continue to see strong performance on our workforce metrics for training and vacancies, and also clinical supervision continues that track record of being above target, which is positive. Operationally, early intervention in psychosis and care programme approach both perform strong, and some really positive performance for our community to our response target, which we know is a focus of the National Oversight Framework. And we are still seeing strong occupancy in our virtual wards. We know the areas of focus are waiting times and sickness, and we've talked about them, and we can highlight in the report some of the action that's been taken place. So, I think broadly a positive position. We have got some pressure points, but we know about them and we're doing what we can within our gift to tackle them. So I'll stop there and suggest we go to questions, Chair.
Okay. Any questions or comments? Phil?
Yeah, I suppose it's a question of grip, really, which is it relates to both to mental health out of area placements and I'm just looking on my notes. So we'll go with that one first. And waits over a year as well, excluding ASD and ADHD. There's about 30 of those. In both those areas, do we individually know who those patients are? And does somebody try to track solutions and sorting them out? Because as a sort of board, particularly with the out of area placements, we need to be assured that they're a result of what's best for the patient rather than a failure of what we're providing in the trust. So that was just a sort of a question around controlling those two key areas, one out of area placements and the other waiting lists where people are waiting over a year.
Who wants to pick that up?
I think Lynn's got a hand up, Caroline.
Lynn? Oh, sorry, Lynn. Yeah.
Thanks, Caroline. Thanks, Phil. Both good questions. On out of area placements, we have a huge focus around acute inpatient flow. Obviously, our target and the national ambition is 0 out of area placements. The two groups that are a bit predominant in that at the minute is PICU out of areas, and we do have a plan that I've been reporting in my section of the CEO report, because we do have too few beds cumulatively, and the gender mix is sometimes problematic, where we need to actually place folk out of area for safeguarding reasons. However, so the plan that we've got in place should address that when it comes on stream next year. The other area where we've got too many out of area placements is older people's as well, and again we've got a plan to increase the bed base. It's actually not hospital beds but community beds, to improve the flow and quality of care. Obviously, every out of area placement we want to avoid, predominantly from a quality of care perspective. Obviously, it's stressful anyway, admissions, but obviously to have family and carers needing to travel to see people out of areas. What we are doing sometimes, which is creating a pressure around adult out of areas, is actually putting older people, if it's appropriate, into our local adult beds and avoiding older people needing to be placed out of area for good quality patient safety reasons. But that means we are putting working age adults out of area. So we are really focused on that at the moment. We've got some issues which we're working on of length of stay, particularly in our PICU as well. Irrespective of the proposal to change the estate arrangements around that service, we need to improve our length of stay, because that is absolutely causing issues around out of areas. They have reduced early in this month as well, which is good to see, but there is a whole programme of work around flow through those beds per se, including obviously avoiding admission where that is absolutely appropriate to do so. So there is a correlation, Phil, with the delayed transfers of care. You've noticed those have risen this month as well, and obviously the two correlate together, unfortunately. We are seeing some issues around our partners in supporting packages of care, particularly for older people where they require intensive home packages or usually residential packages of care. So we are escalating that through the ICB at the moment as well, in order to get that support to achieve those discharges. But obviously they, both of them are not clinically where we would want to be. But we continue with the MAID events, Phil, as well, that we've talked about, the multi-agency discharge process, bringing those agencies into those conversations and obviously escalating where necessary. On the over 52-week waits, not the neuro ones, you can see they are reducing, and our aim obviously is to get those to 0. Phil, you've got the waiting times report coming to the quality committee next time as well, and you'll see in that report the detail of exactly where those waits are and what we are doing to address those. Our expectation is we will get that to 0 over the next few months before the end of the year.
Thanks very much. You mentioned the, sorry, is that all right, Phil, for you?
That's good, yeah.
Good. Lynn, you mentioned the plan coming on stream next year. What time, what date is that? Have we got some sort of sense of when that will happen?
In terms of the PICU plan, we're expecting around April, May time for that plan.
Okay. Thanks very much. Any other questions on this report? Okay, I can't see anybody, so thank you for that. We go on then to item number 17, the risk register update. Welcome, Oliver.
Good morning, Caroline. Morning, everybody.
Can you turn your volume up, please, Oliver? You're very
I'm having some
quiet.
issues today. I'll talk a bit loud. Hopefully that's okay. You can hear what I'm
Keep
saying.
it at that
Apologies.
pace.
Yeah,
Keep
no
it at
problem
that
at all.
level. That's
Okay.
good.
Right, am I okay to go ahead then, Caroline, just with the introduction to the paper? So in terms of the risk register, obviously this represents the current risks with a score of 15 or above, which obviously cited as the trust-wide risk register. So the risks that are reported and monitored by the executive management team. We also obviously included a high-level update in terms of the day-to-day risk register provisions across the organisation since last reported to board in July. So in terms of the content, the highest rated risks, currently 4 entries, which are scored at 15 or above. We've got the ops entry regarding the children's neurodiversity services, which is carried over from last quarter. The two financial risks, one obviously around the external system pressures, and one around obviously our requirements to meet our internal arrangements. And then there's the workforce related risk, which is newly added around sickness absence. One risk has been reduced and is now removed from the trust-wide risk register, but continues to be monitored, and that's WF38, which is the risk around the consultant vacancies. I think we've seen that positive movement in terms of the current position. We have been sort of having those discussions for a protracted period of time within EMT around reducing that risk. So we've taken that decision when looking at the register, obviously ahead of coming into board this time around. So that's now been reduced to a current score of 12. We'll continue to be reporting on reviewed. Will still be reported into the People and OD committee as well. So obviously, should the situation change, it can be re-escalated. And then just in terms of the current kind of risk position across the organisation, currently 146 live risks at the point of reporting, which was an increase from 121 when last reported in July. In terms of the highest rated risks, composition is maintained sort of fairly the same through 12 right up to the 15-16 mark. The lower level risk, we have seen a bit of an increase. There's not a specific area to highlight in terms of increases. I think it's just been a case of obviously new risks that have been coming in via the divisions, obviously reviewed by the operation delivery group, and obviously risks that have just been identified through the process of the risk register. So no areas of concern there. I think it's positive demonstration of that culture across the organisation. So happy to take any questions, any comments. Welcome any feedback as ever, obviously on the current iteration of the register.
Thanks very much. Stuart.
Yeah, hi Oliver, nice to see you again. I recognise all of this from previous discussions and yesterday's audit committee. I just want one thing for the factual record. On the cover sheet in relation to Ops 31, the one about waiting lists, the text says data demonstrates that progress is now being made in reducing over 52-week waiting times. I couldn't see that reduction in the performance report. Just want to check whether that is true or not. It's just for the record of the report itself. Don't need to answer it now, but maybe have a look at it.
Take that away,
the second thing I want to just confirm is that on our risk management, we adopted a new risk management strategy at our last meeting. And we recently had a governors meeting and they were quite interested in the risk management strategy, which is very useful, the discussion. I noted that on our website, it's the old strategy still available rather than the new one. Would you mind just trying to update that
absolutely.
for
I
us?
can follow that up.
Keep us up to speed.
Yeah, no problem at all.
But otherwise, thanks very much.
Yeah, thank you, Stuart.
Cheers.
Okay, thank you. Any other comments? No. Okay, so if you can check that. Oh, sorry, Phil. Sorry, Phil. It's these backgrounds because it's got yellow and black and white. The little things disappearing. Sorry about that, Phil.
Yeah, I mean, I got written down the same thing that Stuart's about that factual.
Yeah.
Probably from what we understand that's not quite correct. I'd just be interested to know what audit thought about the risk rating for that particular risk. Whether 16's the right risk rating for something that I think is quite critical and key issue for our trust, and particularly with some of the sort of assessments that are happening nationally and moving forward, and also carrying literally a huge waiting list, of whether that in itself poses risks to individuals and to the trust. So I'd be interested what Stuart thought.
Good call. We actually didn't discuss or quiz the rating, but it's probably a good prompt to have a relook at it. I don't know, Sarah, you got your hand up. You might want to have a view on this.
This is obviously the kind of the committee that's got the kind of custodian of this risk would sit with the sort of quality committee. Lynn's alluded to the detail around the waiting list report that's come into quality committee this time. What I would be saying is if a risk to be any higher than a 16 would mean that we're actually seeing severe patient harm as an impact of this. And we know that we have a really rough sort of triage and ongoing support into any patient that's waiting on our waiting list. We don't put a patient on a waiting list and then don't have any contact with them for 12 months. So whatever the waiting list is, we have regular check-in points, and obviously we also signpost to other services from an early help perspective to ensure that patients are getting some support in the interim as opposed to waiting for that sort of formal appointment. I know through the datexes that we see that I'm not seeing any harm as a result of long delays and waits. So that would be my further assurance that I would see that would come through our incident reporting as well. But yeah, thank you.
Do you actually have information on when you signpost whether they take it up?
I might have to defer to
What's
Lynn
the
for that
outcome?
level of
Because you can
detail.
signpost all you like, really, can't you? And that's a really good thing to do. But if they aren't taking it up, and there may be families who, for health inequalities reasons, for example, you know, they don't feel confident or whatever, but we don't know if we don't know they're taking anything up. And so if we're checking in, what do we know really about that person and their support network? Lynn, can you answer that?
We don't just check in once, Caroline, we check in periodically.
No, I appreciate that. It's the outcomes of the check-in,
so
I
obviously
suppose I'm interested
through
in.
that contact, it will be identified if people are or are not. And then if they are not, then obviously there is a, you know, opportunity to consider the risk in relation to that. But, you know, we can but guide people to where they can provide that support. Some people choose not to, and they're very clear about that, Caroline, that they are prepared to wait. And obviously on the neuro waiting times as well, there is the right to choose option. And we have written out to patients in relation to that as well, that is an option for them to follow up as well. That might mean some quicker access to diagnoses, although it depends on the provider. Actually, it doesn't always mean they get diagnosis more quickly. But I think we are as rigorous as we can be around monitoring that situation and providing guidance as to relevant support.
I'm hearing that, but I'm not quite hearing, I don't think, and maybe that's something for the quality committee to pick up, is actually what we have as a product of the check-ins to know, and whether there's then a targeted, I don't know. I mean, you can do all the guidance, and I appreciate that people might not follow it up, but I mean, it's your point, isn't it, Phil, about, you know, what's happening to those people, and do we really know if they're actually not in stress or whatever? I don't know, and you might be right. We might have enough data to suppose. Perhaps this is something for you to pick up on the quality committee, because actually looking at what you said, Sarah, about the risk register, quality committee could have a look at this, couldn't they? And they'd be in best position to have that conversation about, you know, what level it's set at. That's what I'm sort of hearing from that exchange between you all.
I'm happy to pick that up with the quality committee, and I can explain that a little bit more so, but we are commissioned to diagnose. We're not commissioned to provide support either. So we do our utmost around that, you know, but and I appreciate the position that irrespective, the waiting list is sitting with us as a provider at the moment, but it is the diagnosis that we're commissioned to provide. Unfortunately, we would love to be in a position, as we keep on talking about providing more support, and the changes in the models obviously is where we need to get to in order to achieve that, which we talked about earlier.
Yeah, well, we'll talk about it in further detail in quality, but whether we may need to have a discussion whether we have a further level of actually auditing the waiting list to see actually what people do while they're sat on that waiting list. I don't know. We'll talk about it.
Yeah. I don't think there's never going to be a simple answer to this. It's really complex, isn't it? Okay, well, that's one for you to take away as chair of the quality committee, to have that discussion with you know, operational colleagues and other members of the committee. So great. I've Oliver and I've got Dean.
Yeah, sorry, it was just, I suppose, to echo Sarah's points and just to give a bit more assurance. I mean, we robustly monitor themes and trends that are coming through each month at Operational Delivery Group and quarterly. and as well via the Quality Insight report to Quality Committee. So very much focused on the risk, as it's obviously the waiting list position and then potential of obviously patient harm, safety impact in terms of linked to that position and any delays. So it's looking at it as an encompassed piece for the risk, and the incident data is not telling us that we are seeing those instances of severe harm linked to waiting lists as it currently stands. Obviously, that's something we continue to monitor, and if the situation, I suppose, did drastically change, obviously that would warrant a change in the score of the risk. But as it currently stands, obviously, that's not what we're seeing from an incident management perspective.
Okay, thank you, Oliver. Dean?
Thanks, Caroline. Oh, it's always useful to get these updates, isn't it, and see that we've got a dynamic approach to risk. And I want to do this on the cusp between the risk register and the board assurance framework, because I'm not sure where it best sits, but it also forces you, doesn't it, to have a look and think, you know, are those our biggest risks and there. And I just in my mind, I just wonder whether we've got, in terms of cybersecurity, so not for any local intelligence or that we're doing anything different locally, but just the external environment seems hotter and hotter and more hostile, and just whether we ought to have a look at, have we got cybersecurity appropriately rated or either reflected in our board assurance framework. I'm not sure where it best might sit, because it's that external environment stuff that's so different. So it's just like an observation when you look at something cold, don't you? And I kind of, in my mind, you might have thought that the above 15s, that lots of organisations now would be looking at cybersecurity as an enormous threat to organisations, given the external environment. So this is not about internal changes or anything, but just the world around us seems to be changing.
Yeah. I don't know whether Pete wants to come back on that. Pete, or I've got, hang on. Stuart's put his hand up. Is it on the same issue, Stuart? Yeah, Stuart, go on.
Okay, well, notwithstanding what Pete might want to add, I think you're right, Dean, that we should kind of constantly think about it. What we do know from our own assessments and assessments by others is that we've got all the sort of the if you like, the defense mechanisms and the internal control process we can put in place to keep our data safe and ward off any hostile activity is pretty good. I mean, pretty good both in terms of the reports that we do of ourselves and benchmarking reports for others in the sector. I think it's fair to say that no organisation, despite everything they can put in place, will ever be immune from, if someone really wanted to get hostile, they would. So the question is the likelihood of that happening? If it happened, there'd be a severe, potentially catastrophic impact, because we know we could see that happening to other organisations. But my sense is from what I've seen through, various channels within the organisation, we're doing everything we can pretty well to safeguard against that attack, but we can never say never. So it's a good call to just keep on our watch. And I guess that is the point of the supporting teams that Pete looks after in data security and the associated IT teams, who keep them patching up to date and make sure we contract with reputable suppliers and so forth. Yeah,
there's a breaking news story that a number of London councils have been hit by a cyber attack where they have a shared system. So again, it's some of those things we're talking about as how we share, and the work on that as well is an issue, isn't it, in this space? Pete, sorry, are you?
I would have said virtually what Stuart said, probably not as articulate. We have the data security protection toolkit. We monitor our IG training compliance. We do annual pen testing. We monitor the patching of our PCs. We update the board bi-monthly, don't we, as part of the care sets update in terms of patches deployed, where we are. Haven't we? The most recent attack we had was a few years back now, and it was a distributed denial of service where we were just inundated with emails and it was slowing our servers down. But we also update the board on that. So, you never say never, Caroline, but like Stuart, I get the assurance from the audit work we do that we're doing everything that's within our gift to protect the organisation.
Okay, thanks for that. Dean, anything else you want to add to that?
No, and as I say, I'm sure lots is going on, and I've seen the stuff when it's picked up in finance and performance as well. It was just that external environment, I think, and anything to learn from Land Rover and Marks and Spencers and others that have recently been hit by stuff. And I'm sure that there's a lot going on in the NHS, as a big industry around that. But yeah, it was just focusing it up. But thank you for the update.
Great. Okay, thank you very much. So on that report then, if we can just get a fact check done on the phrasing under OPS31, and if it does need to be amended, I think it'd be quite helpful for a new, if it's gonna, new wording is put in the report, and that wording, maybe the board support unit could just circulate that amongst the board so you're clear that it's been updated. Great. Okay, and then Phil, you've asked the question. Now you set yourself a task at the quality committee to have a bit more of a discussion on some of those issues around over 52 weights. So you can take that forward. Let's move on then to the board assurance framework.
Thank you, Caroline. Yes, so obviously represents the most recent iteration of the board assurance framework, essentially labelled as Q2 report. I think the main point to note is obviously the slight change to the format of the template, just to try to make it as, I suppose, as easy to pick up as a cold document as it possibly can be. So I suppose clear sort of parity between the inputs, the outputs, as well as the gaps and the corresponding actions. So obviously this is the first, I suppose, iteration where we've kind of taken it through process in this kind of new, I suppose, visual format. Obviously, we're looking to continue to develop the document and take it forward. So obviously, we'll be compiling any feedback from the subcommittees and board. But I think it demonstrates, again, that movement in the right direction. Obviously, a response to the feedback we've had from board and obviously non-execs specifically. And obviously, we'll be looking to take it through our next internal audit annual review as well. So we'll get some feedback from that perspective. In terms of this, obviously not a significant change in terms of the overall ratings, but obviously the content has been reviewed, has been through executive management team, relevant board subcommittees. So as ever, welcome any comments, any feedback. Hopefully it provides the assurance that you are seeking for as the board.
Okay, thank you very much. Michelle?
Yeah, we had a long conversation, as you're aware. Most people, I think, were here at the audit committee yesterday. Obviously, just to conclude with that it is being audited, and we'll just open it to comments today, and I'll intervene as needed. Thanks.
Thanks very much, Michelle. Comments from non-executive directors or any executive directors? Questions? Stuart, sorry. Stuart?
Yeah, do you want me to go?
Yeah, I think so, because we had a good discussion yesterday, didn't we?
Yeah, we had a really good discussion, I thought. So I think just my encouragement is for all the individual committees to look at that. We're all assigned a page on this report. So I encourage all the individual committees to keep your eyes on the content of those individual pages. The tenor of our discussion at the audit committee, yes, was essentially that we still want to make sure that we've got full coverage of all the defined strategic objectives. When I say full coverage, each of those has got some kind of piece of evidence in the report that something's being done, however described, input, output, or otherwise. And I think I think there's still work in progress in terms of the sheer amount of time it seems to be taking, or rather requiring for people to feed the report itself, and then for people to read it and then respond on it. So we kind of want to just not give up on this at all. There's a clear further development to be done, and we, as Michelle indicated, the internal audit team will have a look at it. There's some probably some other design things that we want to keep going on. I still think it's a really useful device, but it needs to have this full coverage, is my conclusion, and that was the kind of the tenor of our discussion yesterday. So more to do, I think, on it.
Thanks very much. Any other comments? Questions? No. Oh, sorry, Michelle.
Yeah, no, that's actually. I mean, yes, I think we did conclude that what Stuart said, but I think, and we do audit it every year. I think what I said. And I will fill you in on because it was about a 40-minute conversation, to be honest, on the BAF. And the auditors were there, so I think obviously they took some useful information away, was that we're in danger of discussing it so much that we're losing the purpose of it, and that we're, I think it's one of those that it is organic, and God, we've changed it completely, over the last 3 years, to be honest. And there comes a point where we have to sort of say, well, let's see where we are, but use it properly. I think that's what Stuart's getting at. But we're in danger of constantly changing it and evolving it, and we're not using it, because like today, it's not on the board agenda for the start and the end of the. That's my fault. I missed that. That we should use it at the start of the meeting, at the end of the meeting, because it drives our strategic objectives, it drives our organisation. So I mean, I can pick that up with BSU, etc. But I think you're absolutely right, Stuart. We do need to get the committees in that mindset, but also just say it's not necessarily about changing the document itself; it's about changing the content of it, so that we're using it and that we're using it in the right way. If that makes sense.
So back to that question, the various questions that we've had in this meeting, either on the performance report or the risk register. What are the things that we're really worried about, and what we're doing about them? That should, smack us in the face from the BAF. We shouldn't need to work hard to draw that conclusion, and then we should be saying to ourselves, is that the right conclusion? And we're probably, as you say, I agree, Michelle. We're spending a lot of time on the kind of the design of the thing, the design of the garment, rather than wearing it and putting on and saying, how does this look? Too many metaphors, but you know what I mean.
Yes. Okay. And okay. Well, I think we had quite a big discussion on this yesterday, didn't we? Which can feed into, some of the outcomes we want. But also, Michelle, yeah, you're right to say, thinking about where we put this on the agenda as well. I think we've obviously, again, we re-looked at our headings based on what we felt important, but maybe there's something about just having some of these items further up the agenda would be probably more helpful. Okay, thank you very much. Thank you, Oliver. And we'll move on to the item number 19, which needs ratification. Michelle.
Virus capability submission, yeah, thank you.
Sorry.
No, so I mentioned this earlier on in the Chief Exec's report. It has gone into region. I think we all saw it by email. It's here just to make sure that we've seen it formally at the board meeting, that we did do a confirmation via email with all the supporting information following our in-person conversations with that. So just to confirm, the conclusions were confirmed apart from one partially confirmed. We have sent in all the required documentation to support those levels, and the levels were the ones that were set in the documentation. And we put a little bit of narrative in each of the boxes, but there is some supporting information, which I think the board have got access to, all of it in the public domain. It has gone into region. We are expecting region to have looked at the submissions and given us an outcome within the next couple of weeks to link into the oversight framework. But it's here for formal notification, Caroline, of the submission and any comments from the board.
Thank you. And it's really helpful just to see us and remind us of the conversations we had and the decisions that were made as well. Any comments or questions? No. Are we happy to ratify? Yes, thank you so much. Moving on to the Assurance Committee reports. I don't know why you've got a proven assurance, Keith, and everyone's just else got an assurance. I don't think you've got anything like you're asking us to approve, have you?
No, not that I'm aware of, put it that way.
No.
No.
So that's just a typo. Okay.
I might have ticked the wrong box. So apologies for that if I did. So this relates to the Finance Committee meeting that we had on the 21st of October. Just over a month ago. I think we changed, as some of you will be aware from previous conversations, we changed the committee format moving forwards into kind of 3 sections for the Finance Committee moving forward. And this comes from the fact that I inherited the original kind of Finance Committee. And I think given the focus we have, particularly around efficiency and productivity, we felt it was important to relook at that agenda. So we changed the committee into 3 key sections. The first one around grip and control, around current finance, which clearly remains very, very important, particularly as Pete alluded to, that our performance is where we want it to be, or in fact slightly better. We then had a large section, probably the meat of the committee, around productivity and efficiency, and how as an organisation we can see that visualize it, and more importantly then provide assurance through the finance committee up to the board that we are where we need to be. And then the third section around things like digital and some of the other areas that we look at, like BAF, and by separating those sections out, we're making sure that we're giving the right amount of time and focus, we believe, to those three different matters, which are quite different now from a finance committee point of view. Overall, finances in, as Pete alluded to earlier, a really good position, a really positive position. I'll talk in private board, Caroline, more about one area. And then also noting really good positive progress around agency and bank spend over the last couple of years, and really significant reductions in agency, but also in bank as well, which is key to some of the success we've had around finances. Some areas on the right hand side around commissioned work, just particularly around the digital update, to try, we've traditionally always had a Be Digital update at the committee, but to really look at that report being a little broader and a little bit more. We talked earlier in the board this morning about giving us really good insight into things that we're thinking of doing and things that we're starting to do, rather than traditionally we've tended to look at stuff that has been completed or is being completed, so that we have a little bit more forward vision on it, which is really important. And also expanding out our view around 3-year cash flow, and particularly CapEx spending. We know that times are going to be as tight or possibly even tighter than they are now, and having that forward view gives us a level of assurance to the board that we are where we need to be, and we're focusing on the right things. We did ratify the annual non-clinical safety report at the committee. Other than that, Caroline, I think I will leave it there, presuming it's read, with any questions.
Thanks very much, Keith. Any questions? No, thank you very much for that, Keith. Move on then to Dean.
Yeah, thank you very much. You got my report there. I put more in the quadrant at the top on this one. This is part of our new cycle of work, given the changing context has been around a workforce and the new cycle of work that we've got. So you can see some new areas there that we've started to cover. But just in terms of the main body of the report, I suppose just to highlight, we had a report in terms of professional education in terms of nursing and AHP. So we've historically done medical workforce and education. So developing work here and looking at the governance that supports that work into subcommittees. We talked about the stuff that we've done on the risk register and the BAF. We also did some work around finance and workforce controls, just looking at the productivity agenda, and again recognising the changing context of workforce in this area. And we covered the 10-point plan, just demonstrating there that we've got cited on that, and also just signed off again against the insightful board domains. But again, like Keith, happy to take any questions.
Thank you very much. Dean, any questions? No, we'll move on then to Steph, Mental Health Ledge.
Thanks, Caroline. Yeah, just a couple of things to draw your attention to. One is the really good work around use of force and reducing restricted interventions. The use of restraint is at the lowest level now for 2 years. Really good work and focus by the teams there across the whole organisation. And secondly, we received some really good case studies around MAPA, which really helped to illustrate that it's not just the facts and figures that we need. Sometimes it's actually the human stories about the difference we're making, which helps us to really understand the services that we're providing. But otherwise, I've summarised the main things the committee looked at this time. Happy to answer any questions.
Any questions? No? Okay, thanks very much. Stuart, Collaborative.
Yeah, thanks. So just going to pull out a couple of things. I mentioned in the discussion with Alison that we'd seen really good evidence in the past about the importance of case management. The other thing that's coming through in this report, which is not new, but it's also working well, is finding alternatives to admission. both for children and young people, and now with adult eating disorders as well. So there's quite a lot of learning emerging about how partners can work together to prevent admission in the first place, which is proving quite effective as far as I can see. And then the second thing is that so one of the partners of the collaborative, the Schön Clinic, has left the party. So the owners of that institution decided they would shut it down, and the process by which the patients were in there were moved to other settings was well done as far as I could see. But it's I think it's probably important to us to recognise that that collaborative is slightly different shape now, but was an orderly exit. And as far as I can see, it's been fully completed now. So that were the two things I wanted to just draw to your attention.
Thanks, Stuart. Any questions? No, thank you very much. Strategic. Can I just say I attended all the committees that were providing assurance reports today, and I just wanted to just praise the work of everybody to those committees and the discussions. Each one, they all have their slightly different personality, I suppose, in a way, but each one was really informative. And obviously, I'm not on them attending all the time, so probably when I come along, I ask things that you all know. But I appreciate your tolerance of me. But all of them, were really doing a great job, I felt, from everybody, and chaired very well. Okay, Board Strategic Development meeting. This is the agenda for December. As you can see there, interestingly, Keith, that you raised about the primary care in your assurance report, and obviously the changes there. We will have an opportunity to have a really good discussion at end of the calendar year discussion about how what's happening, what's progressing, and a bit of a stock take in that space. So I think that aligns itself quite well. Any questions about the agenda? Is there anything anyone wants on there that isn't on there? Obviously, we're having our development side of it is our Christmas lunch together that will be happening after we've done the business. Great. Okay, lovely. Haven't been notified of any items to escalate. I haven't been given any other business. So therefore, we'll go to review of the meeting. I think it's been I hope you feel it's been a good, we've seen some really excellent papers today, I think, and some good discussions and questions and comments by everybody, and that's what we want. Any other comments about the meeting? No? Okay, well, thank you very much. That's the end of our public board meeting. We meet for part 2. It's 12:12. Should we have half an hour for some lunch? You can catch the beginning of the budget statement if you are so inclined, and then let's say we'll come back at 1:45 for the part 2. Okay, thanks very much.
Thanks.